evening, ladies and gentlemen. My topic today is fasten the loops to loosen the clasp. And there is one correction. My hospital is from Kolkata. It is not from the western side. That is not Pune. That is Kolkata. So it's about a strategic reduction of central line bloodstream infections. So I come from the Ruby General Hospital, which is a 316-bedded NABH, ISO, and NABL accredited hospital. It is a 27-years-old organization. And we had the fortune to have late Jyoti Basu, the then Chief Minister of West Bengal, inauguration in 1995, and Mother Teresa visited our hospital, and we have a ward named after her. We know that CLABSI, or central line associated bloodstream infection, is deadly. Mortality 14 to 40%, is costly, average $48,000, and incidence varies from 3.9 to 14 per 1,000 central line days. We were actually shocked when we got this sharp rising trend of CLABSI with 60% mortality in the month of May and June of year 2021. We paid attention to the voice of our internal customers, and we transformed this voice of customers into the CTQ tree, which urged us to reduce the CLABSI incidence by drastically 50%. It was very much urgent and important, and a high priority project with the project priority index of 336. This is our project charter. We had only 3 months to complete it. And our team was ready. We can see the roles and functions of the team members over here. I was a team leader. This Gantt chart matches the actual activities we performed versus the planned activities, both in the project timeline and post-project phase. But what was happening, despite critically looking after the bundle care, supervising, patient was not being saved. So what could be happening? So we did brainstorms, multiple times of brainstorms, and this brainstorm whispered into our ears that we have to listen to the voice of process. So we went ahead with the supplier input, output, and customers of each process step. That is the CPOC diagram. Then we did a healthcare failure mode effect analysis comprising of 43 sub-processes from the insertion and maintenance all processes, giving rise to the hazard score, which is the multiplication product of the severity, occurrence, and detectability. Like in surgical hand wash, in the third line, if the duration and step is not maintained, the failure mode will be the contamination, and severity 3, occurrence 5, detectability 4, multiplied together gives rise to 60. This was the scale we used to calculate these things. Contamination was the major failure mode, and the Pareto chart actually palpated out the fibromyalgic tender points. What were they? Poor surgical hand wash at insertion, unregulated skin antisepsis time, lack of hand hygiene before medication, improper flushing, and delayed central line removal. This decision tree analysis told us which loops we have to fasten first, and we prioritized our aims, which lead us to detect the critical test parameters, and we addressed them. This was our layered process audit as a whole. We can see the green ones are the positive indicators, red are the negative indicators. It has the numerator, denominator, data collection, who collects, how collects, from where, and we can see an improvement from the current performance grade, from the initial to the current performance grade. And there was reduction in the risk probability numbers. Similarly, for the maintenance phase, we had these indicators, both the process and outcome indicators, so that they can compensate. We adapted to a compact set of consumables, including ultrasound probe cover and a sterile hand towel after going the PDSA cycles. And we can know the hand dryer was not at all necessary because our solution selection matrix told us clearly what we have to do. This was our compact set for the central line insertion. So what did we do? We actually reduced the risk stepwise that ultimately piecemealed the failure modes. So this how we fared over time. We achieved the target within the project timeline, and after the project, over the next 4 months, the collapse rate becomes 0. These dots and lines tells us how we ride the bull and finally ended toward the reining the horse. The red one indicates the before intervention and the green one after. We can see hand hygiene insertion, contact time, and other processes over this. So our dog's tail can be kept straightened if we put the controls. And we had this and-on code to tell us the earliest rectification opportunities. This storyboarding format and the communication actually locked this improvement. The lessons were implemented throughout the hospital. Did we gain anything? Of course, we gained $16,000 savings, 0 mortality, and 24% reduction of the risk. A 0.5 sigma process improvement kept the stone rolling down the hill, gathering no moss. And obviously, patients saved over antibiotic, additional stay, and investigations. What could be the secret behind this breakthrough? Yes, the improvement in process capability index and the potential process capability. And there are always some results that are beyond the scope of our measurements, but are the most satisfying ones. Thank you all.
So very nice presentation. Thank you very much. Would just like to confirm the name of the hospital and your name.
I am Dr. Shourabh Maiti. I am from Ruby General Hospital, Kolkata.
Okay, that's wonderful. Thank you. Thank you for the very wonderful presentations. And we'll just want to just head towards the Q&A, right? So it's a very extensive project which you did, and it's quite challenging. So first, I would just like to ask you, what challenges did you face during, implementation of all these interventions, and how did you overcome?
Okay. So, ma'am, I would like to list them first. The greatest,
just 2 main challenges.
Yeah,
maybe there might be n number
the greatest challenge was our mindset, actually. So that happens with every process, the mindset. And second is the haphazardness of the existing process. So we need to streamline that. And I am very thankful that PDSA cycles actually helped us to adapt, because otherwise we couldn't have done this. And definitely mindset remains the main problem. We had to have educational programs and all those things to train all our staffs.
Yeah, that's there. And so I'm sure you must have done some predicted, risk scoring, which you must have done before the implementation of your, tools of risk reduction. And what was this outcome, or what was the actual risk reduction which you achieved? So what was the predicted RPN, and what was the actual RPN which you received?
Ma'am, we started from 688 actually, and ultimately we reduced the risk to 526. Okay. That is a 27% reduction. Okay.
And is there a scope for reduction more reduction in scope, or it's okay? Are you good to go, or are you going to continue this project?
Yeah, ma'am, we are measuring the process definitely, and as we are gathering 0 cases over the months, we are being more vigilant to keep the surveillance, and we are keeping whether our process actually meeting the 6 Sigma requirements or not.
Thank you very much.
Thank you, ma'am.
Dr. Saurav, just 2 quick questions. Good presentation, nice results.
Thank
First
you.
thing is, you have showed that there is a very high mortality with CLABSI. How do you know that this is all due to CLABSI and not due to the underlying condition or the morbidity of the patient?
Yeah.
Yeah. Go ahead.
Okay, sir. Sir, should I answer?
Yep, please go ahead.
Yeah. So, sir, we actually, it is the attributable mortality we calculated, because patient can die of several things, and many times we could not determine. but it is a multidisciplinary committee that decides which event leads to the death. So that's why we have analyzed the deaths and the CLABSI, if I can show the slides, we can have the red mark cases that was clearly attributable to CLABSI deaths. In the green, I have kept as marked as alive. I have given the footnotes that alive includes either death due to non-attributable cause due to CLABSI or some other case, or the patient may be alive.
Thank you. And last question. You are from Calcutta,
Yes, sir.
and you showed the figures in dollars. Any reasons for that?
Yes, sir. Because we searched whole the literature how to calculate the CLABSI. Because you know, if until and unless I calculate in economic terms, the administrator would not understand. So we found did a literature search and found this Agency of Healthcare Research Quality, which is a multi-analysis actually, meta-analysis of 7 studies. So data is more authentic. So our multidisciplinary committee decided that we should use this data and should not differ further throughout the project. So that's why the dollar came over here, and we accordingly calculate our cost to dollar also, you can see.
Good evening. Very good presentation. It's an issue which is prevalent in many settings, and I appreciate your intention to address it, and very happy to see that you have very good results. It's a combination of activities you have undertaken, like different steps, including hand hygiene and other steps. I just wanted to have a clarification. You have mentioned about the central line flushing. What was the kind of solution? Like, was it heparinized or normal saline? Can you elaborate?
Yeah, ma'am. We had the sterile normal saline flushing system, but as you know, we had this post-pandemic, the supply issue was there. So we emphasized to have the sterile saline, that is with the positive pressure, the product particular comes. We try to implement, but in the corporate hospitals, that is not possible all the time. So we did not, our priority was not to have the 100% over there, but at least in 60 to 70% cases, we were implemented those cases. So that remains a weak part of our project, definitely. But as the results show, that weakness has got covered by other processes actually.
Okay. Thank you.
Thank you,
Thank
ma'am.
you.
Thank you, sir. Thanks, audience.